Boob jobs. Let's talk about it. So breast augmentation typically has been the most requested surgery of a plastic surgeon. And what people often don't realize is that while the objective is the same, right, to increase the size of the breast, the way to go about it is so varied between plastic surgeons. Between incision placement, what plane to put the implant in, what kind of implant, do you use an implant at all? There are so many ways that we can do this, and it's just a matter of which way is the right way for you. So let's break it down. Let's start with the kind of implant. So there are two main kinds of implants. They are saline or silicone implants. So what's the difference between them? Well, a saline implant is filled with just that, saline. The one main advantage to saline is that if the implant ruptures, it's very easy to detect because you have basically deflation of the implant. The body reabsorbs that saline. The disadvantages are that unless the implant is overfilled, meaning that you put more into the implant than it says it can hold, then you really do end up seeing a lot more rippling with saline implants. And if you overfill it, then you kind of have this beach ball effect where it feels like a hard ball, a beach ball, and doesn't really feel as natural. Silicone, on the other hand, tends to look and feel more natural. And add to that the fact that there have been advancements in silicone implants in that these days silicone implants are a lot more cohesive, meaning that if there is a rupture, it tends to stay exactly where it is. It doesn't migrate to other areas of the body. What are the downsides to implants, period? Well, there is a risk of rupture. And as I said, if you have a saline implant, then it's very easy to know when it's ruptured. If you have a silicone implant, it's actually quite difficult to know if it's ruptured. If there isn't an associated change with the capsule surrounding it, meaning the wall the body forms around the implant, then there really is no way to know just by looking at a person if the implant is ruptured. The risk of rupture does increase with the age of the implant, and that's why the recommendation is that implants are not permanent, but that they be changed out every 10 to 15 years. Additionally, you are meant to have your implants examined with imaging within 3 to 5 years of the initial augmentation and thereafter every 2 years. The other main risk with implants is that you can get what's called capsular contracture, meaning again that wall, that capsule that the body forms can get hard. Initially, that could mean that the breast implant shape will look a little bit funny. It may look a little bit more beach ball-y than we want it to. And then if it gets to be too hard, it can actually be quite painful. What if you want to augment, but you don't want to use implants? Well, you can also use fat. Fat we can take from really anywhere in the body that you have some excess fat, and we can use that to augment the breasts. The great thing about fat is that it's you and your body, meaning that there's no chance of rejection and there's no long-term having to get imaged to look for things like rupture or capsular contracture. The downside to fat grafting for breast augmentation is that we tend to lose a percentage of the fat that we initially put into the breast. And so for that reason, you may have to commit to more than one session of fat grafting in order to get the size that you really want. Now that we've discussed the implant itself, how about where we put the implant? Historically, there have been two main places to put the implant. Below the breast tissue, but above the muscle, or below the muscle. If we put it below the breast tissue but above the muscle, you have increased risk of infection. You also have increased risk of capsular contracture. The one upside to putting it below the breast tissue is that you do not have what we call animation deformity, meaning that if you flex your pec, there's no change in how the implant looks. Conversely, if we put the implant below the muscle, you have decreased risk of capsular contracture, decreased risk of infection, but you can have animation deformity. Most people don't notice this, but if you are a person who goes to the gym regularly and does a lot of chest workouts, then this would bother you. There is another choice, and that is a dual plane, meaning that on top you have a submuscular plane, meaning that the implant is under the muscle. At the more lower portion of the breast, you actually have the implant surrounded by breast tissue. This has also been thought to confer similar rates of infection and capsular contracture as putting it below the muscle, but you still can get animation deformity. There is actually a third plane, and it's a plane that I have now adopted as my plane of choice, and that is a subfascial plane. To understand what a subfascial plane is, you'll have to know that every muscle in the body has a layer of tissue that is attached to it called fascia. And so by lifting this fascia, we can achieve the best of both worlds. We can provide that extra covering of fascia to have the comparable risk of infection and capsular contracture that you see with putting it below the muscle, but we also don't get the animation deformity. Because it is a very thin layer, it is a challenging way to do this. And so not everyone does it, but it is a great choice for most people without real exception. How about where we put the incision? So again, there are so many places to put the incision. So one is around the areola. If you put the incision around the areola, you get an increased risk of infection and increased risk of capsular contracture. And so generally, I would say that an areolar incision is not really appropriate unless you're planning to do some kind of lift, breast lift along with the augmentation. Some people have used the armpit or the axilla. You have decreased risk of infection and capsular contracture, but it can be an unsightly scar that people will notice if you wear sleeveless or tank tops. And because you're using a small incision in a kind of faraway place, the dissection isn't necessarily precise. And so you can have malposition with this. Another choice for incision is an umbilical incision. Now, I actually don't know anyone who does this, and that may just be my ignorance. But to explain it, it's basically putting an incision in the belly button and putting an implant that way. Yes, you have no scars that are perceptible because they're hidden in the belly button. But again, you're creating a large dissection plane, meaning that you're dissecting up from the patient's abdomen to the breast. And so as such, the placement can be a little bit imprecise and may lead to malposition. The other downside of using the belly button is that you can really only use saline implants at that point, because you're making kind of a tiny pathway between the belly and the breast. The incision that I prefer to use is actually in the fold, in the breast fold. Typically well hidden, unless someone is sitting underneath you looking straight up. It heals well, and it also confers lower risk of infection, lower risk of capsular contracture. So when you go for your consultation, these are important questions to ask your surgeon. Where is the incision? What implant? And what plane? What are your thoughts and questions? Leave comments below, guys. As always, love you lots, and bye for now.